My name is Yeul, a gastroenterologist working at the National Cancer Center, Korea. On the behalf of my co-authors, it is my pleasure to present briefly about journal titled Comparison of the Performance of Risk Scoring Systems for Tumor Bleeding in Patients with Inoperable Gastric Cancer, published in Endoscopy. Tumor bleeding is a minor cause of upper GI bleeding, but in patients with an upper GI tumor, it has been reported to be a leading cause of upper GI bleeding. Because approximately 50% of cases of tumor bleeding were chronic or occurred, it is difficult to decide to perform urgent hemostatic intervention, including endoscopic therapy, transarterial embolization, or surgery in patients with tumor bleeding. In this study, we investigated whether bleeding risk scoring systems such as Glasgow-Blatchford score, admission, and full local scores are useful in predicting the need of urgent hemostatic intervention in patients with inoperable gastric cancer and tumor bleeding. In this retrospective study, 357 patients with inoperable gastric cancer who presented with tumor bleeding at the National Cancer Center, Korea, between 2001 and 2015 were included. The primary study outcome was the performance of the three bleeding risk scoring systems in predicting the need of urgent hemostatic intervention. Secondary outcome was the rebleeding and 30-day mortality. Urgent hemostatic intervention was needed in 33% of the included patients. The full local scores had the highest discriminative performance in predicting the need of urgent hemostatic intervention among the three bleeding risk scoring systems. In a multivariate analysis, endoscopic stigmata of forest class 1A, 1B, 2A, and 2B were significant factors for the need of urgent hemostatic intervention. However, for the prediction of the rebleeding and 30-day mortality, all three risk scoring systems had poor performance. In conclusion, the full local score system was superior to the Glasgow-Blatchford score and admission local score in predicting the need of urgent hemostatic intervention for tumor bleeding. Thus, in patients with gastric cancer, diagnostic endoscopic evaluation is required to determine the need of urgent intervention for tumor bleeding. Our next plan is that we validate our findings prospectively in patients presented with tumor bleeding. I would like to thank you all the study investigators for their contribution to the study and Endoscopy Journal for introduction and publication of our study. Thank you.